Good afternoon, everybody. We have heard some excellent speakers this weekend giving us excellent thoughts and truths about our disease. I'm Tom Hoffmann, and welcome to the Ask the Doctor session. This is where we learn things that are not easily found anywhere else in the Waldenstrom arena. Amazingly, you can't even find them in Google, if you can imagine that. Thank you for sending us questions from the talk list and Facebook over the last 2 months. We have more patient questions today than we can answer in 20 minutes, so some will sadly not be answered. Today we have a panel of some of the brightest doctors in the Waldenstrom arena. I want to thank Doctors Ansell, Treon, Buske, and Minnema for taking their weekend time to teach us. I'm excited to hear them enlighten us again. I would like to introduce them. Dr. Steve Treon is the director of the Bing Center for Waldenstrom's Macroglobulinemia research. He and the people in his lab discovered the highly prevalent MYD88 and its mutations in Waldenstrom. This discovery enabled the very first breakthrough designation by the US FDA for the accelerated approval ibrutinib for the treatment of Waldenstrom. Dr. Treon has published extensively on topics in Waldenstrom and related disorders with over 400 peer-reviewed original reports, reviews, editorials, and chapters. He is also an advisor to the IWMF board. The Dr. Christian Buske, Professor Buske is currently medical director at the University of Ulm in Germany and senior consultant of the medical department. He is primarily interested in indolent B-cell non-Hodgkin's lymphomas, in particular follicular lymphoma and Waldenstrom's disease. He is in charge of the European Consortium for Waldenstrom's Macroglobulinemia. Professor Buske is a principal investigator of several national and international trials in Waldenstrom's. In addition, he is heading a large transitional research group focusing on the biology of the hematological neoplasm. He has published over 200 peer reports. Since 2013, Professor Buske has been the subject editor of a European Society for Medical Oncology Guidelines Committee. He is also a member of the ESMO Hematologic Malignancy Faculty Group. He is on our advisory. Dr. Minnema is new to this forum, and we welcome her. She has recently been added to the IWMF SAT committee, and she practices in Amsterdam, the Netherlands. Dr. Minnema, would you like to introduce yourself?
Yeah, thank you. My name is Monique Minnema. I work not in Amsterdam. I used to work there, but currently I work in Utrecht. I'm a professor of hematology, and I'm especially interested in B-cell malignancies, such as Waldenstrom's disease, but also AL amyloidosis and multiple myeloma. I'm head of the Expert Center in Utrecht. I have a translational laboratory that I do research with, and I also have a special interest in polyneuropathy induced by IgM proteins.
Thank you, Dr. Minnema. And fourth but not last, Dr. Ansell is the chair of the Division of Hematology and Enterprise Deputy Director of the Mayo Clinic Cancer Center in Rochester, Minnesota. He is focused on understanding the biology of the B-cell malignancies and to explore the role of the tumor microenvironment in supporting cancer cell growth and survival. The goal of his program is to translate this knowledge into new treatment approaches for patients. He is a Waldenstrom trustee, the president of the prestigious Waldenstrom Scientific Advisory Committee, and he is the lead person in determining what research projects the IWMF funds each year. He is currently working on an IWMF-funded research project about the factors regulating immunoglobulin-producing B cells in patients with Waldenstrom's macroglobulinemia. We have one disclaimer here for the attendees. The answers that you hear today are not medical advice for any of you. Please remember that any questions that our doctors answer today are for educational purposes only and cannot be taken as medical advice. Medical advice can only be given by your physician. This disclaimer is also for every doctor who tributed this weekend. I will be giving the questions to our doctors, and any member of the panel can start the discussion and give us their thoughts. Others may chime in afterwards if they desire. There's no reason to raise your hands or wait for a prompt. Please be fairly succinct in your answers, as we have a lot of questions. Okay, let's get to the questions. Yesterday, one of our speakers stated that ibrutinib does not kill Waldenstrom cells and that bone marrow biopsies confirmed that. The speaker noted that that was why the IgM rapidly returns if ibrutinib is stopped. Another speaker said that the ibrutinib does kill Waldenstroms, but not early on. Could you help us with this?
Yeah, I'd be very happy to report on this. No, the Waldenstrom cells die in response to the ibrutinib. Maybe perhaps there was some misunderstanding from that particular speaker's vantage point. And we do know this because, as we've done serial bone marrow biopsies on patients, we do see a reduction in the disease. There is, though, this discordance where you will see the IgM drop very abruptly in patients. And then there's a lag time to seeing actually the disease burden go down. Now, years ago, Steve Ansell and his group, taught us a very important lesson, and that is that they showed us that STAT5 was very important to how IgM is made. This is a molecule in the Waldenstrom cells. And I thought this was very important because when we did the trial with ibrutinib and we saw this sudden IgM drop, we also came to recognize that STAT5 is controlled by BTK itself. So when you, in fact, treat the patients and you shut down BTK, you're also shutting down STAT5, and this affects IgM. And the take home on this is from the trial that we did with ibrutinib in patients that had not been previously treated, is that when you stop the ibrutinib, sometimes you have to do that. You have to stop the ibrutinib. Just be wary of the fact that you're releasing this brake once again on STAT5, I think, that allows then the IgM to be made. And sometimes you can have this surge in IgM, the so-called rebound, that one has to be careful about. So just, keep in mind, yes, you are killing those cells, but it doesn't parallel the IgM course.
Yeah, but perhaps just to add, so this question came because ibrutinib is really different than classical chemotherapy, which is really to kill and then exert its effect. So ibrutinib is in some way very special, as Steve very nicely described, that it exerts its effect on different levels, which is like a secretory paralysis, let's say, and then a cell death later on. So it's a more complex, let's say, happening than what we are used by conventional chemotherapy. But to go a little bit into this direction, it might be, Steve and the others should correct me, that we can improve the killing efficacy of ibrutinib by adding a second partner, such as venetoclax, so which then actually probably optimizes the effect of ibrutinib even more by strengthening this killing effect, but keeping the other effects you just described, Steve.
And Tom, just to add to that, I think, go ahead. Monique,
no,
go ahead.
Just one sentence, and I think that was also related to all the questions that were sent in, the stunning effect on the hemoglobin levels when we use BTK inhibitors. So that's also a multi-layer effect that we see when you use BTK inhibitors, that we see a quick rise in your hemoglobin, while perhaps there are still some Waldenstrom cells present in your bone marrow. So that's also, one of the multi-layer effects, I think, of this drug, and which was examined.
And I think just to add to that, I think the challenge is just to think about this as an inhibitor. It's not a chemotherapy drug. So again, it's an inhibitor of a pathway. And when it does that, the cells that are being activated by that pathway and then doing a lot of things downstream of that, that gets shut off. So what happens is the cell stops making proteins that were doing a lot of things like causing the anemia and producing the IgM, but it takes time for the cell to sort of, as it were, wither on the vine before it actually will die off. And most cells will probably just become more dormant than dead. And so in time, that's the risk that they may become reactivated again. So I think it's, as Steve and others have been saying, it's important to realize it's a bit different in the way that it works, and the effects are more prolonged. And to Christian's point, it's probably likely that for us to cure things, we need to do combination approaches.
Yeah. I just want to add one more point, and that is what I think is exciting about this drug, these drugs, the BTK inhibitors, is the effect that they have also on the bone marrow microenvironment. These cells just don't sit in isolation. They interact with other cells that are very important. They produce goodies that help the Waldenstrom cells grow and survive. And many of these cells also are very dependent on BTK and HCK, both of which are targeted by the ibrutinib drug. And when you shut down, BTK and HCK, you're also depriving the Waldenstrom cells of that nourishment, that support that they get from these surrounding cells. And this is why it's a slow attrition or withering. I like that term, Steve. The slow withering of these cells, on the vines, but they are dying.
Great answers. Thanks to all of you. The next question is about an asymptomatic patient with very high IgMs. At what level of IgM or viscosity would you prescribe treatment, or would you wait for symptoms?
So I could maybe start on that. Others will. Yeah. Christian, you go ahead.
No. Go ahead. We will see what we do in Europe. First, the US.
So I joke with patients and say that you want to give treatment the day before you get symptoms. And that, it's very difficult clearly to know when the day before your symptoms are. Well, the object of treatment is to prevent patients from having complications. So there's no, in my mind, absolute number at which one should do things. But I do think you need to be very vigilant to look at trends to have a good understanding of how things are kind of transpiring. And I think, to be frank, we do have some clues that when you get to certain levels, challenges are likely to develop, but they're not the same for everybody. So I do think there's merits to being to individualizing treatment. And I guess I'd make one more comment, and that is, the IgM level and the viscosity are different things. They're measuring different things. So the IgM is the total amount of protein, but the viscosity is how thick it is making the blood. The test for the viscosity is a little bit challenging, and so it's not always as reliable as what we might want to potentially see. And also, different IgM proteins can have different levels of viscosity. So you can have some IgMs that are not very viscous, and you can have a very high protein and not a lot of problems, and others which are lower and have more problems. So I think in part of the package of deciding when the right time is to treat, you need to put all of that into context, along with other symptoms related to how the patient is feeling.
Yeah, I just want to echo on that. We have found the serum viscosity measurements to not be reliable. Back in the day when these were done, manually, they were far more reliable than they are now with digital viscometry. So we've largely abandoned actually following serum viscosity levels, and we tend to focus on the IgM level, as well as the reporting from the patients. Are they having nosebleeds, headaches, blurry vision, the things that go with high viscosity levels, but also a good ophthalmological exam. And this isn't just from the provider. I mean, we should all be trained in doing good ophthalmological exams, but getting a dilated exam and looking for hemorrhages, particularly in the periphery of the retina, becomes very, very crucial. If those are present, you're going to need to treat that patient. But the question, I think, is around, is there an absolute number to which you start treating? And our experience, and I think that's also been true at the Mayo, and I'm also very curious, Christian, what your experiences have been, and yours, Monique, as well. But once, the IgM is above 6,000 milligrams per deciliter, the chances of having symptomatic hyperviscosity go up exponentially. And this is why, we don't tend to use one particular number as a trigger, but above 6,000, we become concerned. And we'd rather treat before the patient does present, with a retinal eye bleed or some other complication of that high IgM level. I'm curious, Christian, how you and Monique in Europe, would handle these types of patients as well.
So we don't measure viscosity at all. Actually, our hospital is not even anymore able to measure viscosity because the last old technician who was able to do this left the hospital, and nobody is anyway doing it, and we don't ask for it. So we very similar. So we start to warn and to explain the patient when the IgM is above 5,000 or 50 gram per liter, and we also see it as more critical above 60 gram per liter or 6,000 per deciliter. So very, very similar. And Monique, I don't know what.
Yeah, I think it's indeed very similar, and also for patients, like what Steve is saying, when you see it approaching, you can also perhaps enhance the frequency of measurements or have a more clear explanation of what hyperviscosity is to the patient, but also to the caregiver of the patient, because perhaps they will see it earlier than the patient itself. But we do also have the measurement of like 60, that's really high, 60 grams per liter. So that's something that I think in the Netherlands we would start treatment and leaving out Rituxan, because that can give an IgM flare, of course, and then even bring patients into trouble. So that's a clear guideline that we have in the Netherlands for these high IgM levels.
Thank you. This next question is probably something that none of you on the panel have ever thought about, and you may need to think about it for a few minutes so that you will have time to decide. I will give you the question now. We will hold the answers for a few more questions have been answered so that you can think about your answer. The question is, if each of you on the panel developed symptomatic Waldenstrom, and all of your tests said that all Waldenstrom treatments will work for you, what treatment would you pick? Please consider approved and unapproved treatments and those in clinical trials. Okay, so we'll go on to the next question and come back to that. Has zunibrutinib replaced ibrutinib at the top recommendation for BTKI drug in your practice?
I can be short in that one because in my practice we still don't have this drug available. I hope it will arrive later this year, but for me personally, I have some experience in clinical trials, and since there was also a comparative trial, I think in efficacy and side effects, this could be a very good first choice.
So should I continue? So
yeah, Christian, do you have it?
So we have both available, so we would be able to give both, and we have also ibrutinib in combination with rituximab as a third option. But I have to say, so it's not black and white still. It depends a little bit also, to whom you are recommending it. So when it's a private practice, we have many private practices in Germany, and they are used to ibrutinib, and there are no reasons not to give ibrutinib. I think it's a great drug. But I tell you, from the tendency moves, or there is a shift towards zanubrutinib very clearly. Also, when you look at the last data of the Aspen trial, which is a randomized head-to-head comparison between Zanu and ibrutinib, I think it's quite convincing how effective Zanu is in CXCR4 mutated and MYD88 wild-type patients. So we see a shift in Germany towards zanubrutinib, I would say.
I think we have to be mindful.
I think Tom, go ahead, Steve.
No, I'll defer to you, Steve. Since your last name begins with A, I'll let you go first.
Oh, Yeah, I think mostly in Waldenstrom's, when the Steve has thought about it, may not be me. But anyway, I think to be frank, in our practice, there has also, agreeing with Christian, a movement a little bit more towards zanubrutinib. And the reason for that is both BTK inhibitors, or all three, but both that we're talking about here, are very well tolerated. So again, these are subtle differences. In general, I think, though, that the side effect profile for zanubrutinib is really excellent. And so most patients tolerate that extremely well. I guess the patients that we sometimes consider ibrutinib in preference are people that have had other therapies and are, let's say, somewhat neutropenic, just because zanubrutinib may have a little bit more of an effect on blood counts than ibrutinib. But I think in general, both drugs are well tolerated. But if I look at kind of the practice pattern, I think there's a little bit more of a favoring of zanubrutinib based on the toxicity profile being even better.
Yeah, no, I think, again, just to kind of reiterate what everyone else has said, we're blessed to have all these very effective drugs. And again, by comparison to, the chemotherapy era, these do represent an aggregate, more effective drugs and, even with less toxicity, both short-term and long-term. But I don't think there's one answer. You can't just say it's all about just zanubrutinib or all about ibrutinib or acalabrutinib, because as you saw in the presentation that I gave a little while ago, there are going to be some patient populations that are going to benefit with one drug over the other. We do think about convenience and compliance in giving, a once-a-day drug like ibrutinib, but we do have also data with zanubrutinib that says you can offer it, and it's even FDA approved to be offered as a once-a-day drug instead of twice a day. You got people perhaps at risk, for atrial fibrillation or for bleeding, where you might favor zanubrutinib. If you want that deeper response, in somebody who has neuropathy, you might favor zanubrutinib. But we have very little data with how zanubrutinib behaves in somebody whose central nervous system is affected by Waldenstrom. Here we have a lot of data with ibrutinib. And then we factor in the genomics, which I think Christian did a very nice job of, reiterating about CXCR4 mutated patients, and even those that don't have the MYD88 mutation benefiting with more so with zanubrutinib. So we still have our job cut out in terms of being able to appropriate which BTK inhibitor is best for which particular patient. But one has to keep in mind there are still these differences that we have to take into account when we're making our decision as to which drug to prescribe.
Thank you. Next question. Do we know what the trigger pathway or mechanism that switches Muggus or smoldering Waldenstrom to become symptomatic?
I'll tell you, we're studying this at this point in time, and there isn't one magic switch. There are some things that are happening to the Waldenstrom clone, that I think are now being picked up in these multi-omic studies. But these are going to be reported at the International Workshop on Waldenstroms. And I think, Steve, you also have some very nice genomic data that's also going to be unraveled there and discussed.
Yeah, I think you're right. I mean, it seems as if there is, when you have more of a monoclonal gammopathy issue and not a symptomatic patient, a lot of that is driven more by cytokines. Then as the cells become genomically more unstable, they become kind of more symptomatic and Waldenstrom's patients. So I think it's a case of an inflammatory sort of environment favoring the earlier stages and a more genomically driven process favoring the later process. But I think, as Steve said, we're still learning about this, and there's still a lot of work and validation that needs to happen. But I think, as with other B-cell malignancies, a repetitively activated kind of environment that makes B-cells more likely to proliferate eventually results in more genomically unstable cells, and then subsequently in cells that actually make mistakes and then start to grow autonomously.
Yeah. And among those events, CXCR4 probably factors into this. So is this huge chunk of chromosome 6 that gets lost, with a lot of regulatory mechanisms that are on there that keep BTK in check, that keep BCL2 in check that we talked about. But the story is far more complicated than just the loss of those particular, that are associated with those mutations.
Okay.
And perhaps I can add something, not on the basic level, but I hear a lot of my patients ask me, what can I do, perhaps to prevent such a transformation? So, but as explained, there is nothing at the moment that we can advise patients to have eat something or do something that will prevent this kind of involvement of your disease. So that's perhaps something that, while we do the basic research, is something important to for the patients to know.
Yeah.
All right.
Very good point.
That's great. Let's go back to the answer for the unanswered question. Should I repeat the question, or can you tell me?
We still know the question, but perhaps I can add something to that question, because the question is now asked at us, medical doctors, but in the Netherlands, we did do a large, we've asked Dutch patients about their preference for therapy, and we published that recently in Cancer Medicine. So it's a review. We asked 214 patients with a discrete choice experiment. So they have two questions laid out to each other, what they would prefer for treatment. So you have certain side effects or certain other points that you want to have, but you find most important or not. And I think in that survey, the Dutch patients said they found the 5-year progression-free survival the most important points to have. So it's disease control. Secondary malignancies were also very important to them. Concerning side effects, especially neuropathy, was more, they would like to prevent as most as possible compared to nausea, vomiting, and extreme fatigue. But also they like more a fixed duration treatment, IV or sub-Q in the hospital, compared to continuous daily oral regimen at home. And they had to choose for existing therapy. So it's a bit different than your question that was put forward. So we were all a bit surprised by these outcomes. And I think my answer, but I can tell that later on, is also perhaps a bit skewed because of the answers that the Dutch patients gave to us when we asked them what their preferred treatment was.
Okay.
So Monique, what is your answer?
So my answer will be that I think it's in line, and I think for me personally, a fixed duration treatment would be something that would be more fitting to me, to myself, and how I see what I want to do in life and how I want to move forward in life over a continuous treatment. But that's, I think it's also what I notice in practice, it's a very personal choice.
So when you think about it, I think you are also again getting aware that despite all this progress, we don't have so many choices. And when you would sit there as a patient, of course we have different agents, but nevertheless, despite this progress, it's still limited. So when I would think about me personally, I think I would avoid chemotherapy, I would say. So I think I would really try to avoid, despite the fact that we are responsible for European guidelines, for national guidelines. Despite we say still also one of the standards is rituximab chemotherapy, but I would avoid it. So I would go with Monique for a timely fixed duration treatment. So probably I would have a little bit courage, although these data are not out, but I would probably go for a BTK inhibitor and venetoclax. So I would probably participate in a clinical trial testing this. Why? Because it's a targeted treatment. We discussed let's say, the delayed effect of ibrutinib, and let's say one of the some way weaknesses of ibrutinib. And by venetoclax, I'm sure that you can stop ibrutinib, that you are able to stop ibrutinib. So probably I would go into such a trial and would be quite convinced that I'm doing something correct. With a little bit risk, of course, because we don't know the data, but we'll know them soon, I hope. So now,
Steve, you go first this time.
Yes, thank you. It's very seldom that people at the end of the alphabet, get prioritized. But this is a good question. I've thought about this quite a bit. I think, reducing secondary cancer risk is really important. I think about this whenever I see a patient. And for this reason, I've deprioritized the use of alkylator drugs like bendamustine and cyclophosphamide and others in my practice, because unfortunately I have seen those patients who have emerged with acute leukemia or other side effects, cancer side effects from these drugs. And I think, if you can avoid this, you may not be able to in all circumstances. One should be able to do this. And so, a BTK inhibitor, I think, would be probably the drug that I would think about. There are circumstances to the disease I might present with that may make me think otherwise. If I had amyloidosis or if I had big, bulky lymph nodes, if I presented, it might sway me to use bendamustine or a drug like bortezomib. So it's gonna factor into how I will present. The idea of fixed duration versus being ongoing on therapy wouldn't bother me as much, because when I think about it, if I had high blood pressure or diabetes or cholesterol problems, I'd be on a drug for life. I mean, we don't cure those by giving people short-term, therapy. So it wouldn't bother me every day to get up, in the morning and take my ibrutinib or my zanubrutinib as a therapy. And the idea of optimizing therapy, whether it's CXCR4 antagonists or venetoclax, is exciting. And maybe they will offer us some way of being able to, keep therapy to a shorter duration of time. I'm not sure, Christian, and I think, at ASH this year, we'll be presenting the data of the ibrutinib venetoclax study. I don't think that's the answer because of potential toxicities. But there may be other, opportunities using other BTK inhibitors with a BCL2 inhibitor that may get us there. Just like in CLL, where they can give now 15 months of therapy and then stop and get good responses, and then patients are off, doing their own thing. But again, getting therapy every day, taking a pill every day to prevent, your cancer from recurring or progressing, I don't see a shortfall to that. But I can see the appeal also to a fixed duration of therapy. And we will get to it in Waldenstrom's. We just have to do the right trial. But I plus V isn't the answer at this point in time.
Okay. No, I didn't know. Okay, good.
Yeah. No, it'll be presented. It'll be presented at, I think actually at IWWM, we'll see some of that data coming out as well.
Mm-hmm.
So I guess from my perspective, everything I would recommend for a patient would be something I would do myself. I don't think it's morally acceptable to recommend to patients what you as a person wouldn't consider. So again, one has to say, and I think others made this point, is everyone is very different and what you value is different. And, I'm someone, for example, who takes no medication. So taking a medication would be something that would be a big change for me. So I personally, when you say fixed duration, I want the shortest treatment that's going to give me the greatest benefit, and I can stop having to think about needing to get treatment every day and get on with my life as best I can. And so that to me is what's attractive. So fixed duration for me is very attractive, but fixed duration for me is in any context, not just medications that are pills that we're going to give for a fixed duration, but even treatments that one would give intravenously. So I guess I commonly will recommend to patients to consider bendamustine and rituximab. And I would consider that for myself, because data, particularly from marginal zone lymphoma, would say I may only need 4 cycles of treatment and still get a very durable remission without any maintenance therapy. And I guess the point I would also make is that chemotherapy is one thing, but BTK inhibitors and BCL2 inhibitors are not no therapy. They have their own toxicities, and durations of treatment over time bring on their own side effects. So everything has consequences. So while there are consequences to chemotherapy drugs, there are consequences to novel agents too. And so I think all of that needs to be factored in. But if it was me and it was tomorrow and I would have to go, I value clinical trials, I would always go on a clinical trial. But I would probably favor a treatment that was done in 6 months or less.
I'm curious, Steve, if you and I now are not 40 years old, but let's assume we were, would your decision be different than if we were 70-year-olds? I mean, because I think that's really important. Would you expose?
Yeah. So again,
expose if there was an alternative, a young patient to an alkylator therapy. That's why I'm.
Well, so again, I have to put my hat on there that I treat a lot of lymphoma, not just Waldenstrom's. So, and I give 40-year-olds, a lot of them, bendamustine and rituximab in the context of other lymphomas. And if you were to say, what are the consequences in younger patients for those patients? Who am I seeing that are getting many of the toxicities that we potentially fear? The answer is not as many as you think, actually quite few. And younger patients, if you take follicular lymphoma, and Christian's an expert, he should chime in too, a younger than 40-year-old patient with follicular lymphoma can have an exceedingly good long-term outcome. But we're not seeing as many profound problems with, leukemias and those kinds of things. And although there are increased numbers of second malignancies, many of those patients are the people that needed more treatment and got other drugs and then got a transplant and etc. So one of the complicating factors is it's not just as cut and dried as you think. So my view is that everything factors in, but I think Monique made this point, and this is really important. This is a conversation between the patient and the provider, because the patient's desires are really important, because it may be different, as you point out, when you're 40 compared to you being 70.
Yeah, this just shows that all of us are different. Thank you. The next question. There are several Waldenstromers on the talk list who are in their late 80s and 90s. Some are frail. We know that Cytoxan can transform Waldenstrom to DLBCL, but that takes many years and a heavy dose to do so. Would Cytoxan pills be the best treatment for them? And if they could go to an infusion place, would RCD be better?
Yeah, just want to clarify to the person asking that question. I don't think we've seen an increased risk associated with transformation with cyclophosphamide-based therapies, and the other panel members can answer. But we have seen it with drugs like fludarabine and cladribine, and that's been documented in studies by us and others. And so I think the bigger concern with transformation of disease is with that class of drugs, with those, they're called nucleoside analogs. And in fact, the drug of choice for somebody who develops that type of transformation is in fact a cyclophosphamide-based therapy. It's referred to as CHOP. You usually give it with rituximab. And in fact, the survival rates tend to be very good for people who transform and then are treated with R-CHOP. But I would defer to the other panel members for their own experiences as well.
Well, I would just add to that and say, Steve, you're completely correct. The other thing I would say is that I don't believe that oral Cytoxan or oral cyclophosphamide is a preferred treatment in a patient like this. We had this conversation just minutes ago about BTK inhibitors and their good toxicity profiles. I would certainly say in an 80-year-old relatively frail patient, a BTK inhibitor would be highly effective and probably exceedingly well tolerated, and would be, in my mind, a preferred treatment in that patient rather than going down that risk. If there was transformation, Steve's entirely correct. That's totally different. It's a new disease. It's a totally different thing. But if I would not factor in the likelihood of transformation into my treatment decision, and I would probably say oral cyclophosphamide would not be a combination that I would consider. And I would personally favor a BTK inhibitor approach over the DRC regimen in my practice.
So if you were 80 years old, so you're telling us now that if you were 80 years old, you would have taken the BTK inhibitor?
And frail, which I'm right now afraid I'm not.
No, but I agree with Steve. So I would say the same. And so the secondary transformation following CHOP. So they're very nice data sets also in follicular lymphoma, and it's very clear that the risk of secondary transformation after cyclophosphamide is quite low. So, but otherwise, I can just repeat what both Steve said. I would also go for a BTK inhibitor. Of course, when it's so fragile that it cannot swallow anymore. But otherwise, I think it's a very fair and a very good treatment option for elderly, also frail patients. I would also not go for cyclo orally.
I concur, and perhaps according to some different situations, when only anemia is the reason to start treatment, perhaps also some intravenous iron can fix that problem without starting treatment. But that's a very selective, I think, situation. But in general, also in our country, in our guidelines, BTKs are more preferred when in elderly patients and frail.
Okay, thank you. Good answers. Next question. We are told not to eat CYP3A4 food like grapefruit with ibrutinib or BTKIs because it can double or more the blood level of ibrutinib and cause severe reactions. In light of that, why does an 80-pound lady get the same dosage as a 240-pound man who is not obese? Should be getting 3 times the dose that the man is getting.
Yeah, I think that's a great question. When the dosing of ibrutinib was developed, it wasn't developed in the classical way where you just keep upping the dose and then you see toxicity and you roll back. It was determined biologically by looking at what dose was necessary to shut down BTK activity. And so that had some shortfallings. And in fact, this was recognized in the study that Dr. Sorosiak did when she looked at the patients that required a reduction in ibrutinib dosing. And it turned out it was actually more likely to be in a female patient than it was in a male. It was more likely to occur also in an older patient than a younger patient. And so I think there's a lot of merit to the question that's been put forward to us. It just wasn't addressed in the most comprehensive way as it might have, because it was, again, a biological determined dose as opposed to classical one, which is weight based, that we often use, or body mass index.
I think Steve's entirely correct. I think most of the biological agents were struggling to work out how you optimize the dose, because a maximum tolerated dose is not relevant. Most people don't have one. But the challenge is just you trying to find an effective dose with the least toxicity. So I guess to answer the person's question, that's quite correct. The dose may actually probably vary, and we could probably use less or more in different circumstances, but we have no clear data to say that's what we should do. So that's where we're kind of stuck at this point. But to the reason why you want to avoid these CYP, inducers that could cause problems, that's where you're interfering with the enzymes. Grapefruit will do that as a way to then cause potentially higher drug levels. Because you're taking the drug every single day, if you do something that changes the biology of how that drug is metabolized, you can end up with problems down the road. I know that I said can, not will, because many people probably will still be fine, but you just want to be careful not to have more bleeding, more irregular heartbeats, more other issues which you might be able to avoid if you just simply changed your diet a little bit.
Yeah, I think just to add, so we see it's really, there's a gray zone, but on the other hand, I think we should also emphasize that you should really stick to the dose as a patient. So don't reduce the dose or, take this as a take-home message, because there is a gray zone. What we said, that you start to play with your dose. You should stick to the dose, because the data we have with the dose which is prescribed to you as a patient. And in Steve's group, there are also data showing that when you reduce ibrutinib, you might compromise the efficacy of the drug.
I have no additional information on this.
Yeah, I just also want to add one other, practical point. If you do go on a medication, just make sure you run it by your oncologist to see if it might impact your BTK inhibitor, because there are also antibiotics that are out there and other, blood pressure controlling medications. With acalabrutinib, there's drugs that actually, are used for controlling acid reflux that could be affected. Just make sure you run by any new drug you might be started on by your hematologist oncologist if you're on a BTK inhibitor.
I think Steve's exactly right. And the other thing is any supplements that you're taking, because some folks don't regard those as medications, but also have some effects.
Yeah, good point. Actually, fish oils turned out to be one of those surprises, Steve. When we were doing the ibrutinib trial, patients were presenting with nosebleeds, and this is a blood thinning medication as well. So you should report your supplements. I think that's a really very important point.
Okay, good answers. The next question, compared to covalent BTKIs, what do you think about the non-covalent BTKIs like pirtobrutinib?
Well, they're very exciting drugs. The big question these days is, where do they get positioned? With pirtobrutinib, that we have the most data on, the impressive part to this drug is it tends to have very little risk for arrhythmia. In fact, in a fairly large, safety data pool, the 2 patients who had arrhythmia were patients that already had a prior history of an arrhythmia, of atrial arrhythmia. So by and large, it looks, at least with pirtobrutinib, we're still working with nemtabrutinib. They look like a very safe class of drugs. The issue as to where they belong, do we give them before a covalent BTK inhibitor like ibrutinib or zanubrutinib or acalabrutinib, or do we give it after? This is where I think there's some room for debate, because the non-covalents are very dose dependent. As I was saying during my talk, these are drugs that don't just come across BTK and then bind and are cemented to BTK forever, like the covalent ones do. And so they're going to be more dose dependent. And I think, to the earlier question that we were posed, there may be some variability among patients as to what the ideal dose may be. So for this reason, because they're not like cement where they just glue on to the other protein and then are stuck there, there's going to be, some differences, I think expected differences in their long-term activity. And that's data that we still don't have. We don't know how long pirtobrutinib's effect is in these various diseases. And so I think for this reason, the covalent ones will still be preferred, even though they may carry some more side effect profile. But time will, I think, shed light on where they belong. Right now, they belong after covalent BTK inhibitors, when patients are either intolerant to them or they have one of these BTK mutations.
We have to state
I think
that.
Just to piggyback on that, go ahead.
We have just to state most of the data are really not in Waldenstrom. So we have most of the data in CLL and mantle cell lymphoma. So in Waldenstrom, data are really still limited. I think, Steve, you are doing a trial at the moment, but I think our experience is still very limited in Waldenstrom.
Yeah.
I think the merit also is in, as we give more and more patients the BTK inhibitors, we'll have mutations to deal with that happen as kind of a natural selection of cells when they get drugs that are given over long periods of time. And I think the newer drugs will be particularly useful in those patients.
Yeah. So the data in CLL looks very nice. So I totally agree. It's a very exciting drug, but I think we still have to know more and research more on it.
Okay. Will the non-covalents work better for CXCR4 wild type, MYD88 wild type? Do we know?
We don't, because the limited data that's come out of Tony Mato's study that included a whole, group of B-cell malignancies that, including Waldenstrom, that were treated, didn't explore genomics. There is a study now that Dr. Castillo will be pursuing that will be dedicated to Waldenstrom patients. So we'll have the opportunity to examine both MYD88 and CXCR4 impact on pirtobrutinib's outcome.
Okay. What are you telling your Waldenstrom patients about what they should be doing concerning COVID vaccinations?
If I can go first, I think we are very blessed with the COVID vaccination. So I'm a big supporter of vaccinations of all kinds. So all the vaccinations that we have in childhood, influenza, and also for COVID. We do know that, especially with Rituxan or rituximab therapy, the vaccination response can be nil or extremely limited. So in that case, perhaps you can be vaccinated, but I'm very doubtful if you are doing Rituxan therapy or recently had Rituxan therapy, if you have any response, and perhaps your vaccinations are less useful, but still you can have some T-cell responses. So also in those cases, I do recommend vaccination and also booster vaccinations.
Okay.
Yeah,
Just agreeing with Monique. I would.
No. Beauty before age. You go first.
Yeah. I think in our practice, we're strongly recommending, like Monique, that boosters and vaccinations are done. We're also asking patients, if they were to get COVID, to be very quick to see their provider to receive medications that are very effective in helping. And we also recommend the prophylactic antibody treatment Evershed as a way to try and prevent people from having problems, especially if you're on treatment.
I completely agree. So Evershed plays a major role in our hospital also for these patients, and otherwise, as Monique said. So yeah, we recommend vaccinations for sure.
Yeah, I just want to echo that we have a study that we'll be presenting at the Waldenstrom's workshop, and it's also been submitted to ASH, that has actually looked at how patients have responded who have gotten their initial vaccinations and then boosters. Boosters appear to have played a huge role in being able to gain immunity. So I do think this is going to turn out to be very important. And I can't emphasize enough, if you can get access to Evusheld and your titer levels against the vaccine are low, please consider getting the Evusheld prophylaxis.
Perhaps just as to add, so perhaps also a question to the others. So we are a little bit more reluctant to give bendamustine in the era of COVID to these patients because of the quite detrimental effects for B and T cells. And perhaps the second remark is we should not try to compromise the therapy because of COVID. So we should try to give the patient the best anti-Waldenstrom treatment despite COVID. And I think this is also very important because we have many patients who are irritated and don't know what to do. So I think it's important to stress that you should continue to give the best anti-lymphoma treatment also in the era of COVID.
Yeah, I think this is a good message, Christian. And for the audience's sake, when we have looked at outcome to vaccination, both having rituximab-based therapy within the last year and being on a BTK inhibitor, both were, mitigants of vaccine response. So I don't think we saw a difference in terms of the ability to mount the vaccine, a response to the vaccine, whether you got bendamustine, Rituxan, or you were on a BTK inhibitor and needed therapy. So for this reason, I think the point you made was very good about giving the best or ideal therapy. But, back to our community once again, please get vaccinated, please get boosted. That's what seems to make a big difference in terms of getting your immunological status improved against this virus.
Great, thank you. Could you please give us an update on CAR T results? Who should consider using CAR T?
I can certainly start on that. I would say, the data. Go ahead.
No, Steve. I think you have experience. We don't have any experience with CAR Ts in Europe so far. There will be a trial starting, I think, end of the year, beginning next year, but we don't have any experience. So I think you have.
Well, I think the main thing is that the experience is very limited. There's small numbers of patients treated in a number of trials. And I think the good news is that CAR T-cell therapy is highly effective. And I think it's a potential treatment in the future. And particularly if we look at other malignancies where CAR T-cells are used, they have proven across the board to have significant benefit. However, I think what's really important is to weigh up risks and benefits. I think we know that especially in the beginning of treatments that we were all talking about are very effective and the results are really excellent. And the risks of CAR T cells are pretty substantial. And some of the challenges is that when you're done, you may end up with low blood counts that are long-term, which then limit options potentially down the road. So in our practice, we're doing CAR T cell as potential for patients, but we really have it as sort of probably third, fourth line types of approaches when other more standard treatments have failed. So it's only in a very small minority of patients at present.
Yeah, I think the data that's come across with CAR T has been very limited. Leah Palombard and her group, recently published their 3-person experience with CAR T therapy that looked very promising. And Mazar Shadman is going to present the Seattle experience at the International Workshop on Waldenstroms. But I think also to sort of broaden our immunotherapy arsenal, there's also this class of drugs known as bispecifics that are also very exciting. These also help drag in the immune system, particularly T cells, but also natural killer cells to engage the tumor cells. There's a number of trials now that are looking at this in various other lymphomas and Waldenstroms. We're about to embark on one of these trials. But I think these represent a more off-the-shelf ability to be able to deliver therapy as opposed to the customization that's necessary for CAR T-cell therapy. And the side effect profile also appears to be very different. So I think the era of these immunotherapeutics is coming our way. Maybe it took a little bit longer than the other diseases because BTK inhibitors did so well. But I think we have to recognize that we still have now unmet need in the era of people either not responding or progressing on BTK inhibitors.
Okay, next question. Multiple people have stated that they have had a large IgM flare after receiving IVIG. One patient had an IgM rise of 1,300 in 3 to 4 weeks after an infusion. Why does IVIG cause an extreme increase in IgM in some? And is that IgM from the Waldenstrom or from other?
Yeah, I'd like to take a stab at this because we have experience with this. This flare appears to be a bystander effect. when we initially had reported on the flare, and I think, Maury Gertz had reported on this, and Thanos Demopoulos, we were intrigued as to what mechanism could possibly account for this. So we went through a couple of postdoc students where we take the Waldenstrom cells, culture them, add in Rituxan, and we'd see nothing. And then it became obvious to us that in two patients that we treated with IVIG, they also had profound, increases in their IgM. And then we began to think, well, maybe this has nothing to do with Rituxan binding to CD20 on the Waldenstrom cells, but maybe this has to do with bystander, other immune cells that are also in the microenvironment. And it turned out that was exactly the case. Once we added in monocytes and neutrophils into our experimental conditions, the Waldenstrom cells flared. And this was because those immune cells were making cytokines, proteins, inflammatory proteins like IL-6 that were goosing up the Waldenstrom cells to make more IgM. And there were ways of blocking that. In fact, the trial that Christian, led, the Innovate trial that he recently published, he very nicely showed that for the patients that got ibrutinib along with Rituxan, they had a very, very low flare rate compared to the patients that got placebo plus Rituxan. And so it has to do with the ability to churn out these inflammatory cytokines that's actually creating the flare, whether it's IVIG or Rituxan. It's been documented also with ofatumumab as well. Christian, maybe you might have some more to say about that, because that was a wonderful observation in your study.
No, I think nothing to add, Steve. It's a major difference. So when you add ibrutinib, of course, so what we saw that you really more or less didn't see any IgM flare. So it's a clear-cut difference, which of course is a quite expensive way to, let's say, to reduce the IgM flare. But it's absolutely correct. Yes.
Yeah. Well, I'll tell you, we've
Steve,
also done the opposite. No, please go on. I have one comment there, but I'd like to do it after you.
No, just to your point about the cytokines, Ken Anderson and your group had shown right back, well, at the beginning of the BTK story, that one of the mechanisms by which BTK inhibitors may work is inhibition of cytokines. So it could, exactly right. So that Christian's right. It's a very expensive way to suppress cytokines. Steroids would probably do just as well for a lot less money. But bottom line is probably cytokine mediated, as you say.
Yeah. I'm going to say that we actually also had the opposite experience in all the years that we did trials where, when we gave people the IMiDs like thalidomide or Revlimid or pomalidomide along with Rituxan, those are immune stimulating drugs. We had the opposite effect where patients flared, and they flared for months and months and months, and we had to do plasmapheresis to chase down the flare. So we've seen both ends of this, drugs that stimulate the immune system, making the flare worse, drugs like the BTK inhibitors, which actually block the effect. But one important message for our community, if you have a high IgM level, be very careful about being on Rituxan, because the flare rate, flare occurs in about half of all patients with Waldenstrom's. Why it happens in some and not others, we still don't know. I mean, we've looked at this very, very carefully, but the answer is we don't know. So in general, we recommend that if your IgM level is above 4,000, that you don't see Rituxan. Maybe you should go on the chemotherapy or the BTK inhibitor by itself, get the IgM down, or have plasmapheresis, get the IgM down, but don't expose yourself to rituximab, because you can throw yourself into a hyperviscosity crisis if the IgM flare occurs.
Thank you. Next question. We now know that venetoclax increases the AUC tremendously of ibrutinib with drastic results. How are the trials with a lower dose of ibrutinib with venetoclax doing?
Oh, I can answer that because we've done the trial and are still following up on this trial, but that hasn't been done yet in terms of looking at lower doses of ibrutinib. We stopped the study of ibrutinib and venetoclax, and all the patients have been followed and continue to be followed, and the data will be reported very shortly on what those consequences were. But there's no plan at this point that I know of to look at alternative doses of ibrutinib along with venetoclax.
Okay. Why does the Cancer Therapy Advisor and National Comprehensive Cancer Network still state 6 courses of bendamustine rituximab? We know that 4 courses work very well for us. Shouldn't they say 4 to 6 courses depending on the response or something like that?
Agree.
I can start on that one. Most of the data is really being supported by 6 cycles. So when you're actually providing guidelines, it's best to be based on where the most data lies. And so I think that's the reason that the guidelines are erring on the side of caution, and quite appropriately so. Sometimes in practice, we will do things differently and still are very comfortable with the results. But I think guidelines are there to guide everybody and not just and so that's why I think it's a better strategy to stick with what the clinical trial data would support.
Yeah, just to add, so I think it also is a little bit due to the German studies from Matthias Rummel. So because he did 6 cycles of R-benda, but when you look very carefully at his studies, you see, for instance, in the maintenance trial, so that 1/3 of the patients dropped before they actually achieved the time point where they're randomized between maintenance and just observation. So 1/3 of patients were lost, which quite nicely demonstrates that 6 cycles is too much for many patients. This is, I think, I completely agree, Steve, the data are with 6 cycles, but I think it would be great. So I would, probably agree when you would write 4 to 6 in our European guidelines.
Yeah, I think it's disingenuous to actually put the number of cycles down when we also have data. And I think there's data from your institution too, Steve, as well as ours, looking at the outcome of patients who got 4 versus 6. And in fact, we're seeing very similar outcomes and even less toxicity. So I think, when you're providing these guidelines, remember, most people that are out there in the real world aren't Waldenstrom experts. They're going to follow what's in the guideline. And this is why I think it is really important to give this sort of additional guidance that for many patients, 4 cycles is plenty.
If I can add something, I think it's quite different if you look retrospectively and you compare 4 to 6, that perhaps there were reasons for patients to receive 4 because they had a very quick result or they had some toxicity. So there can be different patient characteristics why 4 to 6 can look the same. Having said that, I do think that, of course, you have to look at every patient. And if with 4 R-benda, you achieved the goal that you want to achieve, and you can discuss that beforehand with your patient, then of course 4 can be enough. But in some patients, 6 is a better option.
Yeah, for somebody who has, let's say, big bulky lymph nodes, there may be a necessity to go beyond 4. But for a lot of patients, you're able to achieve very long-lasting benefit with just 4 cycles of therapy. I also want to point out that when the FDA approved bendamustine here in the United States, it even approved a dose of 120 milligrams per meter square that we don't use. I mean, almost everybody gets 90 mgs per meter square.
Wow.
Yeah. So, but these guidelines, these are the United States guidelines, the NCC, and you are both a member of?
Right.
Okay, so it will be fixed then.
Yes,
exactly
it
what
should be fixed.
Yeah, I agree with you. The next question, why are we tested for kappa and lambda light chains? And after diagnosis, do they ever need to be tested again if the first one was benign, except for those, of course, who had trouble with light chains or in trials?
Perhaps I can start with that one. If I understand the question correctly, at diagnosis, we normally test all the M protein-like types of proteins that you can have. So the M protein, kappa lambda, IgA, IgG, IgM, and also IgD, just to select the one that is most appropriate to follow in time. In Waldenstrom patients, it's mostly the M protein or the total or the total IgM. And the free light chains in the standard Waldenstrom, so not in amyloidosis patients or light chain deposition disease, seem to be not so important to see responses or to guide the patients through a treatment. So in the Netherlands, now in my institution, I do measure all the proteins, all the immunoglobulins, all the M protein-like proteins, but after that I select the one that is most appropriate to follow the patient's condition. And in Waldenstrom's, it's M protein and or IgM, and I don't use the light chains anymore because I don't feel they have additional value for the patients.
Monique, since you have a lot of interest also in the amyloid patients, do you follow the light chain though when you're treating somebody with amyloidosis?
Yes, and I must say, then I have more. I follow the light chains even more than the M proteins because they have a very quick response to treatment. And of course, I also follow the M protein if it's present, but then it's the opposite. Then it's FLC's free light chain measurements. And I also measure both because in the response criteria, you have to calculate the difference of the involved and uninvolved light chain. So then it's completely the opposite in AL amyloidosis. But I consider that a different disease from standard Waldenstrom's.
Yeah, I think we do all the same, I guess.
And it can be confusing to patients because it's a lot of proteins that we are measuring, and sometimes, like in AL amyloidosis, we also measure protein Benz-Jones, so M protein in the urine. So I do see that it can be quite confusing to patients. But then I would like to follow the message that Bob Kyle always said to patients: know your M protein. And I think we as physicians should help our patients to see what M protein is important to you to follow.
Okay, sounds like everybody agrees. And the next question, we have always been told that Waldenstrom anemia is caused by crowding in the marrow, the garden. But my hemoglobin, and by my, I mean me, was 8, B12, iron, everything was normal, and only had 10% Waldenstrom cells in my marrow. Please explain this.
Yeah, I think it's important for the audience to recognize that the anemia of Waldenstrom's can be complicated. There are patients who have a lot of disease, and this explains their hemoglobin being decreased. But when we've looked at the relationship of hemoglobin to bone marrow involvement, this doesn't necessarily, associate, hand in hand. And that's because the Waldenstrom cells can make this protein called hepcidin, which can block iron from being absorbed by the gut. It can also cause cells in the bone marrow called macrophages or monocytes. These are scavenger cells. It can actually induce them to gobble up all the iron and hoard it, just like squirrels hoarding, nuts. And they deprive actually the red blood cells from getting those, getting the iron. And you can stain the bone marrow and you can find iron there, but it'll be in the wrong cells. It won't be in the red blood cells. And so, check your iron levels. If it looks like your iron saturation level in particular is low, then sometimes giving intravenous iron will help get, the iron where it needs to go into that red blood cell. And also keep in mind that for a lot of patients, they make their IgM or other antibodies that are made by their bone marrow actually bind and destroy the red blood cells. This is called hemolysis. We had, one of the earlier cases that we were presented was a hemolysis case. This can also, with a very low bone marrow burden of disease, also destroy red blood cells. And I would say one other mechanism potentially is, the spleen sometimes can get big, and you can see this gobbling up of red blood cells. So there could be a lot of factors here beyond just how much crowding occurs in the bone marrow that one should look at if the patient's presenting with a low hemoglobin and a low bone marrow disease burden as well.
Okay. Next question. A CLL study has shown that there is no reason to do bone marrow biopsies after the first one for diagnosis in their future clinical trials. Will Waldenstrom trials do the same?
I can maybe start with that. I think, again, one of the things I always teach fellows and residents that work with me is never do a test unless you know what you're going to do with the result. So you do a test because the test will inform you about something. So we have a number of ways where we can track and follow the disease in Waldenstrom's. And one of them is obviously, as we've been talking about, the IgM protein. But quite frankly, as Steve just very nicely pointed out, sometimes what's going on in the blood and what's going on in the bone marrow are not the same. And there actually is kind of significant differences, particularly, for example, in the case we were just talking about, where we would assume an anemia was associated with lots of bone marrow involvement, and then it is not. Other things are going on. So it may not be necessary to do as many bone marrows over time because you may be able to get the information you need from some of the blood tests you're doing. But I will say that it is more common that it gives you more information than it does in CLL to do a bone marrow in Waldenstrom's. And I personally, anytime there's an uncertainty about what's really going on, that's when I think those tests can be very helpful. And I will typically do a bone marrow to clarify if things aren't as clear as I think they should be.
Okay, thank you, Dr. Ansell. Somebody else?
Well, perhaps I can add that CLL, of course, is a leukemia, so it's a blood cancer. And like we said, we sometimes we need the cancer cells itself to demonstrate, of course, it's a cancer, but also to follow up. And therefore, in Waldenstrom's, where you don't have that many circulating tumor cells, there are perhaps a bit, but very, very low. It's not like a leukemia, so we still, I do agree, we still need bone marrows when we think this information can help guiding the patient.
Okay.
Yeah. So what I think Steve said, we only do it when it has any impact or consequence for the patient. So I think the patients can be sure that we not just do it, but really when we think it's necessary. Yeah, we don't do it just to confirm any clearance of the bone marrow when there is no complete remission by other surrogate markers and so on. And so I think it's necessary, but we do it in a very controlled way, at a minimum necessary.
Yeah, and Tom, just add, sometimes also we do it because we don't have the genomic information that, we need to make some of our treatment decision-making. I think it's very helpful. And if a patient is on a clinical trial, a bone marrow usually is done because it helps also assess the efficacy of the drug.
Okay, thank you. That actually is part of the next question. Can CXCR4 and MYD mutation be tested with peripheral blood?
Mid-88, yes, because it's the studies have shown that in untreated patients, you can see a sensitivity and specificity level as high as you would if you did a bone marrow biopsy, but only in untreated patients. CXCR4 is a little more complicated because you can't use the PCR technology that tends to be more sensitive. For there, a bone marrow would be desirable. But there are some variants now, like the nonsense variants that we talked about, in the previous hour during my talk, that tend to be the ones that are associated with lesser response to BTK inhibitors. Those are PCRable, and I'm sure this is going to come up at the next workshop where we're going to discuss what may be the more important mutations for us to look at. The other, interesting engineering that's being done out there to pick up these mutations is cell-free DNA analysis, where you're not even looking at picking up cells. You're actually just looking at floating DNA that's present in the bloodstream. And those are actually also becoming a very exciting source for being able to do blood testing determined mutational analysis.
And perhaps I can add to that's also coming in the next workshop, that our student Karima Amador, she did this cell-free DNA testing for the mid-88, so not the 604, and we did pick it also up in relapsed patients. So I think that is a very promising technique for the near future.
Tom, just to add one thing to that, one of the things just to remember is that it's easier to find these mutations in the blood by cell-free techniques or whatever when the disease is out of control or relapsed or newly diagnosed. The more treated it is and the lower the disease burden, the harder it is to find that. So it really, again, depends on where in the disease course you're doing this test. And if the likelihood of there being active cells is lower, you need to get closer to the source. So I would just say if someone is being treated and you still want to know the information, a bone marrow becomes critical. If you're trying to get it out of the peripheral blood, your likelihood is pretty low. So again, it's a timing in the disease course becomes relevant as well.
Yeah. I'd like to just add, to that the excitement here is also that we can use these changes in the burden of these mutations to follow patients. And I think, this may be another ancillary way beyond IgM to be able to determine, how a patient is doing on treatment. So it's good that we have these mutations because it does give us also a potential for assessing response to therapy.
But probably it's very important that we improve the technology, that we are able to do it from peripheral blood in the future, because everything else will be not feasible. Yeah, so we see it in other diseases and other lymphomas. So I think it would be great when at some time point we don't need bone marrow anymore, because who wants to be bone marrow punctured again and again? I think this is really not feasible. So we have to work on these technologies for sure.
You notice that Tom Hoffmann didn't ask this question of the panel, which one of us would like to have a bone marrow biopsy as part of our treatment?
So I had already two as a student, so I know how it is.
Well, let me tell you, Dr. Barloghi gave me 4 in less than 4 months. All right.
We do them sedated, which I think helps.
Yeah. I think you've already just answered the next question, but I'll just check to be sure. It says, does everybody need a bone marrow biopsy for checking mutations before they start a BTKI? Does that everybody agree with that?
Yes.
Well, I think that, but it can be the first one. Perhaps if you start your BTK second or third line, I don't think it will change that much. So correct me if I'm wrong, Steve, but.
No, it's stable.
We've looked at this, and the folks that were did not have the CXCR4 mutation, at diagnosis didn't acquire it later in the course, so it's unlikely to change with time.
Okay. Does a patient with a high bone marrow involvement and simultaneously relatively low IgM levels present with different symptoms?
So low IgM, high bone marrow burden.
Yes.
Yeah. Though you see, quite a spectrum of how bone marrow involvement can present with regard to IgM, Tom. I remember one patient that we had to do 4 bone marrow biopsies because this patient had severe hyperviscosity. So IgM level well above, 12,000, and yet, the bone marrow biopsies that were done were all turning up normal. And in fact, at the end, this patient had less than 0.5% tumor involvement in their bone marrow. But to be able to start therapy, we needed a malignant diagnosis, which we didn't have.
Thank you.
I think the other thing that this highlights is just how different things can be. And again, making sure that you've got all the information you need. If you have discrepant results in the bone marrow and the blood, that's where it's useful to have both pieces of information because you can manage the patient best. So I don't know that the patients present differently as a group, but each patient may have different symptoms. And again, a comprehensive evaluation is what's needed.
Okay, sounds really good. Next question. What current treatment will preserve our immunity best long term? And is there a better one in the drug pipe?
Well, I'll say, if I can, that this is why I'm excited about BTK inhibitors, because when you look at what Rituxan-based therapies potentially do is they can erode away the good antibodies, the IgA and IgG, which help, fight infection. We don't see that effect as much with BTK inhibitors. And of course, we've moved away from the era of using nucleoside analogs like fludarabine, which used to damage the immune system quite badly. And, patients would end up with various, problems like shingles, for instance. Proteasome inhibitors like bortezomib also did the same too, during the time that the patients were being actively treated. So I think in that regard, the era of BTK inhibitors has lessened this burden on Waldenstrom patients.
Yes, I do agree. But what you said, Steve, is that still with vaccination, they also have some diminished responses there. So I think in the end, I do see the importance of this question, but I think in the end, also with CAR T cells and the dual bodies that are coming up, suppression of the immune function is present in some different degree, but in all therapies. And also in myeloma that I see a lot of patients with, I don't see a therapy in the future that can have this immunity not being challenged by our therapy. So I think that's something that is still there and will stay there, I think, for some time.
Okay, good. I think the best thing is to cure people so they don't need more treatment, Tom.
Yeah.
If we, as we move toward treatment that hopefully is one and done, we were talking about, constrained treatment over a period of time. If we actually have therapies which we can administer over a short course and get a very durable result for most patients, that's the best thing for their immune system.
Okay, that's good. Okay, why do some people have solid Waldenstrom tumors, and how does the Waldenstrom cells get to those areas?
So I think what is meant that they have enlarged lymph nodes, or when
just solid, just under the skin tumors.
Okay, I haven't seen those patients, but we do think that the cells they can travel throughout your body. So the immune cells have this capacity to go where they are needed, and when a B cell transforms to a Waldenstrom cell, they remain this capacity. So they will travel perhaps throughout the bone marrow, go out a little bit, go in a different place. They go to your spleen. So they use the blood system or the lymphatic system to travel abroad, and they will home where they feel comfortable. I don't think skin tumors is something that is common I have never seen it, so perhaps somebody can
Yeah.
have a more right comment on this.
I've had a few over the years, Monique, and they're exceedingly rare. But of course, you also have to make sure they're not amyloidomas, which we can also see in some of the patients. Important, actually, just to share with the audience that at time of diagnosis, it's unusual to see, enlarged lymph nodes or spleen or tumors outside of, the bone marrow. But it becomes more common at time of relapse, where almost half of the patients may have, disease outside of the bone marrow. So it's not uncommon. Why you see this trafficking may play in some part, on the genomics. The folks that are CXCR4 mutated tend to have less disease outside of their bone marrow than the patients who don't have these mutations. So the genomics do play a role. But then there's, specific tropism. Why is it that in some patients it goes to the brain, in other patients it doesn't? For this, we still have, very elementary, answers to.
Sometimes you have also to be careful because sometimes it's difficult to differentiate between different lymphoma subtypes. So, for instance, when you go to the skin, marginal zone lymphoma is sometimes very difficult to separate from Waldenstrom. So this is also something you have to consider.
Yeah. Thinking back about that case earlier, Tom, I just want to, on that point that Christian just made, somebody who has a very low IgM and a lot of bone marrow involvement, just, we have to make sure that patient isn't somebody who has marginal zone, lymphoma, which sometimes can look very much like Waldenstrom's, and they tend to present with very little IgM. So, it's important to make sure we get the pathology right on that particular case.
All right. We've seen several people with solid tumors in their spine, around their spine, that radiation really took care of.
Yeah.
All right. The next question: what treatment is best for symptomatic enlarged lymph nodes?
I tend to prefer bendamustine in that setting if they're very large lymph nodes. They're bulky. But drugs like ibrutinib and zanubrutinib can also decrease, lymph node size and spleen size if they're not, extra large or oversized.
Okay. All right, that's good. Sadly, our Ask the Doctor time is about over. This will be the last question. Dr. Treon, have you had any more horses or cows with Waldenstrom, and did they develop COVID?
So, I think this goes back, for those of you who may be new to the panel, goes back a few years when, in fact, there was a case of a dog in France that developed Waldenstrom's. And there was also a cow. And I don't know how the veterinary doctor was astute enough to diagnose Waldenstrom's even in a cow. We still try to get tumor to actually do mutational testing on both, but both of those animals were unavailable at that time. But animals like us, are prone to these tumors. In fact, dogs tend to have aggressive lymphomas very typically occur in dogs. And in fact, ibrutinib that we have today only got vetted out and, developed as a drug because it was shown that it was very effective in dog lymphomas. So we have animals to be thankful, for helping us guide human medicine as well.
Amen.
Did the cow with Waldenstrom's have yogurt for milk?
Yeah, I'm not sure, Steve. I just, again, I think it was about hyperviscosity, and a good retinal eye exam is what revealed the diagnosis in the case of the cow.
Okay.
Got it.
I want to thank each of our amazing doctors for taking their time to respond to our questions and for being attentive to each and every detail. These answers are priceless and will help many of us. Let's give them a huge virtual applause. I also want to thank all of you in the audience again for sending the questions and viewing the presentations. I hope these answers will help all of you on your Waldenstrom journey. Now I would like to introduce Newton Guerin, the IWMF President and CEO, who has some special announcements and news to share with you. Thanks to all. Bye.
Well, I think we can all agree that session absolutely lived up to its incredible, long-standing reputation. So Dr. Hoffmann, thank you so much, and a special thank you to our panel members, Doctors Ansell, Buske, Minnema, and Treon. You know, we greatly appreciate really everything that you do for the IWMF, and especially for people living with WM. As a reminder, all of our general sessions are being recorded and will be available on demand at our website. That's IWMF.com. You should be able to access them within the next week or so. And for all of you who played WM Trivia, I'm happy to tell you that we actually have some winners. Shelley from our home office will announce their names in the chat, so everyone can see, who the lucky winners are, and she'll be in touch with them in the next few days to give them a chance to pick out any item of their choice from our online store. So thanks to everyone who participated. I hope you had some fun. I certainly enjoyed it. I didn't do very well, but I enjoyed it anyway. Can we see the first slide, please? Now I'd like to congratulate 5 winners who actually will receive complimentary registrations to next year's Ed Forum, and they did this by being entered in a raffle. Everyone that registered for this year's Ed Forum by August the 1st was entered in a raffle, and I'm happy to say that we have chosen 5 lucky winners, and here they are: Andrea Horton, Joel Rosenblit, Allison Wachstein, Lisa O'Laughlin, and Wolfgang Meinhard. So congratulations to each of those folks. Next slide, please. So these last 2 days have really been incredible, and now our Ed Forum is about to wrap up, but before we say goodbye, I really want to say thank you to some very special folks. First, our session MCs and moderators. I think everyone will agree that they did a great job, and we owe them our thanks for keeping us both on task and on time. So thank you. Next slide, please. None of this could have been possible, obviously, without our incredible presenters who all donated their time and expertise to be with us over the last couple of days. So thank you. And I want to thank our Ed Forum sponsors again. A special thanks to Beijing, our title sponsor, along with our contributing sponsors, Selectar Biosciences, Pharmacyclics and Janssen, the Treadway Foundation, and X4 Pharmaceuticals. So now we're on to our 2023 Ed Forum. It's scheduled for April 21st through the 23rd at the Hilton Hotel at the Ballpark in St. Louis, Missouri. We're about to take a look at a short video to give us a sneak preview of what we can expect. We sure hope to see you all there. And on behalf of all of us at the IWMF, thanks to each and every one of you for joining us as we continue to live, learn, and thrive with WM.